Good afternoon, honorable professors and healthcare professionals. Sawadee Kap, Mingalaba. First of all, I would like to say thank you to all doctors, professors, and healthcare professionals for joining our webinar event, and let me kindly introduce myself. My name is Dr. Wee Imon from Sunland Trading Company Limited, and I'm presenting as MC for this webinar event. I would like to welcome to you all for today's event, the role of warfarin in cardiovascular predicts. For this event, may I kindly introduce Professor Uke Malwin, retired professor, Department of Cardiovascular Surgery, Yangon General Hospital as chairperson, and Dr. Surin Wirgit Kumpor, MD Division of Cardiovascular Thoracic Surgery, Department of Surgery, Faculty of Medicine, Chiang Mai University, Thailand as speaker for sharing his experience, and Dr. Lin Taozin, Consultant Surgeon, Department of Cardiovascular Surgery, Yangon General Hospital as speaker for the role of warfarin in cardiovascular predicts. Before we get started, I would like to go over a few agendas so you know how to participate in today's our webinar event. Agenda 1. Opening the webinar for the role of warfarin in cardiovascular predicts and welcome speech by Professor Uke Malwin. Agenda 2. Professional educational talk by speakers Dr. Surin and Dr. Lin Taozin. Agenda 2 includes sharing information about the role of warfarin in cardiovascular predicts by Dr. Lin Taozin and sharing cardiovascular experiences by Dr. Surin. Agenda 3. Question and answer session by Professor Uke Malwin, Dr. Surin, and Dr. Lin Taozin. If you have any questions throughout the webinar, please write them down in chat session and they are going to be answered in this session. Agenda 4. Warfarin product presentation. Agenda 5. Closing the event successfully. According to Agenda 1, I would like to open today's webinar event for the role of warfarin in cardiovascular predicts. To begin this event, we are pleased to have Professor Uke Malwin for deliver welcome speech.
Good afternoon, everybody. Alaman Mingalaba. Mingalaba. I'm very glad to participate in this CME program today, sponsored by the SBS from Thailand and the Sunland company from Myanmar. And this is a combination. And we also have two speakers one from the Thailand, and Dr. Surin, who is a senior consultant cardiothoracic surgeon in Chiang Mai University. And from Myanmar side, I have Dr. Lin Taozin, and he's a senior consultant cardiovascular surgeon in Yangon General Hospital, which is one of the biggest teaching hospitals in Myanmar. And today we are talking about warfarin, and which is one of the old molecules for the anticoagulant therapy, but there's a definite role in the treatment of cardiovascular practice. And Dr. Surin again will also present his experience in cardiothoracic surgery in Chiang Mai University. And now I think Dr. Lin Taozin will start role of the warfarin in cardiovascular surgery practice.
Thank you, Professor Uke Malwin, for your wonderful welcome speech. According to Agenda 2, I would like to invite Dr. Lin Taozin to share educational knowledge about role of warfarin in cardiovascular predicts.
Good afternoon. I'm Dr. Lin Taozin from Yangon General Hospital, Myanmar. Today, I'll take in the first part of this section, the role of warfarin in cardiovascular practice. First of all, I'm not a pharmacist or physician, but I'm the cardiac surgeon who handle with this warfarin every day with my patients. So today is some of the lecture slides or presentation slides regarding the warfarin in our cardiovascular practice. Let's start the slides. Slide, please. Okay. Role of warfarin in cardiovascular surgical practice, and this is a background. So regarding history, it's known as the Coumadin. And warfarin first came into large-scale commercial use in 1948 as a red poison. 1948 is the Independence Day for Myanmar. Warfarin is formally approved for human use by US FDA in 1954 in the treatment of the blood clots. Warfarin stands for the acronym WARFRIN, stands for Wisconsin Alumni Research Foundation, and the Urin, linked with the coumarin. Warfarin is already, you all know that warfarin is a vitamin K antagonist in hepatic microsomes, interfere with formation of vitamin K dependent clotting factors, and it also inhibits protein C and protein S. So prescribed in these slides. VKR inhibit. Most of the vitamin K is obtained from food and small amount synthesized by intestinal bacteria. Regarding pharmacokinetics and dynamics, onset of action, it's oral, it takes 24 to 72 hours, and full therapeutic effect on day 5 to day 7. INR may increase in 36 to 72 hours. Duration is 2 to 5 days, and absorption is by oral, which is rapid and complete. Half-life elimination is between 20 and 60 hours, in mean 40 hours. Protein binding capacity 99% and metabolized by the liver and excreted by the urine in 92%. And before talking about starting the anticoagulant drug, we need to remind some of the scoring system. Two scoring systems, one for the thromboembolic risk assessment in atrial fibrillation, known as the Sept score, and another one is the Hasblat scoring for bleeding. One for thromboembolic risk scoring, and one for bleeding scoring. This one is a Sept score. Maximum score is 9. Score of 3 or greater indicate high risk for stroke, and oral anticoagulant therapy is recommended. Regarding Hasblat score, maximum 9 points, and Hasblat score 0 means low risk for bleeding, 1 to 2 marks indicate moderate risk, and 3 or more indicates the higher risk of the bleeding in our patients. So what are the indications of the warfarin? Two main things. One is to prevent thromboembolic events, example stroke in atrial fibrillation patients or the valvular heart disease patients. And another one is the DVT and pulmonary embolism. Indications. For STEMI, it is recommended that warfarin use can be restricted to patients with atrial fibrillation or documented LV thrombus or a large akinetic or dyskinetic LV segment. A meta-analysis of observational studies show anticoagulated patients had an 86% reduction in embolization rate. This is the main indication. Valvular heart disease with atrial fibrillation, valvular AF. According to 2020 ACC/AHA guideline, here you can see patient with rheumatic mitral MS. Sorry, I didn't write down the shortcuts abbreviation of these such things. Sorry, mitral stenosis, rheumatic mitral stenosis, long-term vitamin K antagonist. Anticoagulation is indicated for class 1 indication. Native valvular disease except rheumatic mitral stenosis, warfarin or NOAC based on their Sept score. This is the class 1 recommendation. Regarding bioprosthetic valve, regarding tissue valve, more than 3 months after procedure, warfarin or NOAC based on Sept score, and new onset AF within 3 months of the valve implantation, anticoagulation with warfarin is indicated. Indication 2A. So let me highlight this number 4. In patients with mechanical heart valves, with or without atrial fibrillation, who require long-term anticoagulation with VKA to prevent valve thrombosis, in these patients, NOACs are not recommended. Here is handful sign. So, mechanical heart valve require lifelong treatment with warfarin, guided by the INR, International Normalized Ratio. NOACs currently have no role in patients with mechanical heart valves patients. This is the 2021 ESC/EACTS guideline, European guideline. Regarding valve repair patients, the patients who have high incidence of new onset atrial fibrillation and recurrence, thrombogenic tendency of the non-endothelialized repair components, and relatively high rate of patients who are resistant to aspirin, warfarin as a preferable option for initial period. Example, the first 3 months after surgery. This is the guideline, 2021 guideline. Oral anticoagulation with vitamin K antagonist should be considered during the first 3 months after mitral repair and tricapsule repair. It's a class 2A indication. Regarding VTE and pulmonary embolism, warfarin has been used for more than half of the decades, and so patients with DVT, warfarin should be initiated concurrently with intravenous heparin or low molecular weight heparin. After this, oral anticoagulation should continue for at least 3 months. Target INR is 2 to 3 years effective. Long-term follow-up is required. Indefinite treatment of warfarin should be considered in some patients, such as patients with recurrent DVT, patients with risk factors such as antithrombin 3 deficiency, protein C, protein S deficiency, and patients with persistent antiphospholipid antibodies or patients with malignancy. In these patients, indefinite treatment of warfarin should be considered. For documented pulmonary embolism, either low molecular weight heparin or unfractionated heparin should be given, followed by oral warfarin continuing for approximately 6 months in the absence of recurrence. However, should there be a recurrence, indefinite therapy should be considered again. And warfarin can also use in the cardioversion, DC cardioversion, especially in elective cardioversion. This is the indication of the warfarin. And this picture is taken 4 years ago, Mr. Chairman, Professor King, and me in operation theater. So regarding drug interactions with warfarin, warfarin is famous for various drug interactions, approximately 80 or 90 of the other drugs. Some inhibit, some promote. Let me skip these slides. Okay. Drug interactions with warfarin increase anticoagulation. That is, INR increase and blood become thin. Allopurinol, amiodarone, sertraline, diltiazem, cimetidine, ranitidine, omeprazole, very common drugs, inhibit warfarin metabolism. Broad-spectrum antibiotics causes reduction in vitamin K availability. And even acetaminophen para inhibit the VCOR in VCOR in the synthesis. Quinidine, NSAID, and clopidogrel, and also depression of the platelet and promote the action of the warfarin. Some drug interaction with the warfarin decrease anticoagulation, barbiturates, cholestyramine, rifampin, etc. And vitamin K is Actually, I don't need to say any more vitamin K because warfarin is a vitamin K antagonist. One important thing is the oral contraceptive pills. COC inhibits the anticoagulant effect by increasing the synthesis of clotting factors 7 and 10. So when we're treating our patients who are taking COC, we have to be cautious with the use of the warfarin. Warfarin dose may be, increased dose of warfarin may be needed. The safest rules is to tell the patient or oral anticoagulation not to take any over-encounter nor any new drug without consultation, and for physician to checklist any new drug that is used. If in doubt, INR should be monitored more frequently. And also, dietary changes are anticipated, as maybe an example during travel period. Adverse effect of warfarin. Hematologic is a bleeding, and regarding cardiovascular, it may some side effects such as maybe hypotension, syncope, vasculitis, some CNS effect, elevated liver enzyme, and some hypersensitivity reaction or the some Purple syndrome. These are some side effects of the warfarin. Contraindication to warfarin. Warfarin is the anticoagulant, so its side effect is bleeding. So, recent stroke, uncontrolled hypertension, hepatic cirrhosis, and potential GI and genitourinary bleeding patients. If anticoagulation is deemed essential in these patients, we have to consider risk-benefit ratio. Old age itself is not a contraindication against anticoagulation. Regarding CKD patient, warfarin doses for moderate reduction of the renal function may need reduction, while watching for increased warfarin stability. Approximately 25% in a small study for a mean creatinine clearance 47 ml per minute. So we need some dose adjustment in CKD patients. Pregnancy on warfarin. Warfarin is totally contraindicated. During the first trimester because of its teratogenicity, and also 2 weeks before birth because of the risk of the fetal bleeding. Warfarin crosses the placenta barrier and results anticoagulation effects on the fetus as well as the mother. There is a higher risk of the fetal intracranial hemorrhage if the mother is fully anticoagulated with warfarin during vaginal delivery. So how can we handle this? One approach is to use warfarin or low molecular weight heparin in the first trimester, then again warfarin in the second trimester till about 37 or 38 weeks, and then changing to heparin or low molecular weight again, which is discontinued 12 hours before labor induction. Warfarin is then restarted in postpartum again. Heparin should be regularly monitored by APTT and low molecular weight heparin by ND 10E levels. Heparin requirements increases in third trimester because of increased heparin binding proteins. So what is the target INR? Generally, the aim is moderate intensity of inhibition of INR 2 to 3. INR 2 to 3 is appropriate for patients with DVT with pulmonary embolism, those at risk of thromboembolism, and for EF. Regarding prosthetic heart valve, warfarin is recommended in mechanical prosthetic heart valve, usually level between 2.5 to 3.5. This is only a rough value. However, meta-analysis proposed a relatively high target of INR 3 to 4.5. Aortic mechanical valve at the lower end, that is near 3, and mitral near 4. But there's a little variation between studies. This slide shows the target INR in mechanical heart valves. It depends on the patient-related risk factors and their prosthesis thrombogenicity. You should give on these calculations according to 2021 ESC guideline. Regarding bioprosthesis mitral valve, tissue valve, risk of thromboembolism is highest in the first 6 to 12 weeks when warfarin is mandatory. Then you can follow antiplatelet therapy. Strong evidence for continuation of warfarin when mitral bioprosthesis valves are combined with atrial fibrillation, large left atrium, or LV failure. For bioprosthetic aortic valve, the risk is low when compared to mitral, and so aspirin for 6 to 12 weeks is appropriate. According to guideline, in patients with no baseline indication for OAC, oral anticoagulant drug, OAC using a VKA should be considered for first 3 months after surgical implantation of tissue valve in mitral or tricapsid position. Recommendation level class 2A. Another one is a bridging therapy. Bridging. Patient with prosthesis heart valve in whom interruption of anticoagulant therapy is sometimes needed for diagnostic procedure or sometimes surgical procedures. A bridging therapy with either intravenous and fractionated heparin or low molecular weight heparin to reduce thromboembolic events during temporary interruption of the warfarin. This is the guideline, and for patient with mechanical heart valve undergoing minor procedure such as dental extraction, according to guideline, continuation of warfarin is suggested, with the therapeutic INR is recommended. For patient with bileaflet mechanical aortic valve replacement and no risk factor for thromboembolism who undergo invasive procedure, temporary interruption of the warfarin is suggested without bridging agents. For patient with mechanical heart valve who is taking warfarin, who require emergency non-cardiac surgery or invasive procedure, we need to reverse with prothrombin complex concentrate. Patient with tissue heart valve or annuloplasty ring who receiving anticoagulation for atrial fibrillation, it is reasonable to consider bridging anticoagulant therapy with heparin. For patients with undergoing invasive procedure, mechanical aortic valve replacement and thromboembolism risk factor, or the older generation of the mechanical valves or mechanical mitral valve replacement, bridging therapy is recommended. Another section is the warfarin overdose. Management depends on whether the patient is bleeding and why they are warfarinized. Bleeding increases exponentially with increasing INR, especially more than 4.5. Some guidelines said more than 6. Major or life-threatening bleeding and need urgent surgery, warfarin should be discontinued and oral 10 mg vitamin K infusion is needed and repeat every 12 hours if needed. In urgent surgery, vitamin K infusion. Prothrombin complex concentration, PPC or FFP therapy should be initiated according to body weight and pre-treatment INR. And recheck INR at 30 minutes and every 4 to 6 hours until normalization. In the absence of bleeding, PCC or FFP therapy is not recommended. Asymptomatic patient with INR more than 10, VKA must be stopped, and oral vitamin K 2.5 or 5 mg is prescribed, and INR is monitored again on daily purpose for 2 weeks. Asymptomatic patient with INR less than 4.5, careful down titration and or skipping is enough. This is a guideline. In patient with mechanical valve and controlled bleeding who require immediate reversal of the anticoagulation, we should give prothrombin complex. It's reasonable. And urgent use of intravenous vitamin K is reasonable. INR self-monitoring. Since the warfarin need monitoring with INR, the use of this self-monitoring INR is associated with low rate of vitamin K-related complications in all ages. But patients' education level plays an important role in this self-monitoring. Effective management of patients with unstable INR requires frequent in-clinic testing and dose titration with their physician. Because of lack of good quality evidence, pharmacogenetic testing cannot be recommended to guide the dose of VKA. This is a guideline. Patients with VKA, INR self-adjustment is recommended if they get the appropriate training and quality control. Level 1 indication. Another is a NOAC or direct oral anticoagulants. I'll not discuss about these in this section. This is some example of the dabigatran, epigatran, NOAC, and the warfarin action sites. This is an interesting 2021 ESC guideline indicates native valvular heart disease. NOAC become recommended recommended in patients with aortic stenosis or aortic or mitral regurgitation, not mitral stenosis. These are some papers regarding the oral anticoagulant and antiplatelet therapy. In patients with peripheral arterial disease, combination of oral antiplatelet and oral anticoagulant is not more effective. And in this study, neither oral anticoagulation with warfarin or platelet inhibition with aspirin is better for mortality in heart failure with sinus rhythm. But giving warfarin, there's 20% reduction in non-fatal cardiac events. But risk of major bleeding is increased. This study is the oral anticoagulant and antiplatelet therapy for PAD patient. This shows oral anticoagulant plus antiplatelet therapy may improve the acute limb ischemia and major amputation and stroke risks compared with antiplatelet therapy alone, but still bleeding risk is increased. This study shows effectiveness and safety of the NOAC versus warfarin in patients with AF and aortic stenosis. But observation needs confirmed large randomized trials in commonly encountered patients. Study is still ongoing. And the use of anticoagulants in PAD is mainly effective in the vein graft in arterial circulation. The others are controversial. Another one is a transition from NOAC to warfarin. Should be undertaken in consultation with specialist advice. Important points to consider are NOAC half-life, which is affected by renal function and delay in onset of warfarin. So, a starting dose of warfarin, 5 mg or less is recommended. For patients with estimated creatinine clearance more than or equal 50 ml per minute, NOAC should be ceased when INR target greater than the baseline plus 1. For example, patient INR baseline is 1.5, NOAC should be stopped when INR is greater than 2.5 on 2 consecutive days. If the baseline INR is not elevated, then cease the NOAC when INR has greater than 2 for 2 days. This is the end of the presentation. Thank you.
Thank you, Dr. Lindhausen, for sharing your knowledge. Now, let me kindly invite Dr. Surin to share professional knowledge about your experience of cardiovascular practice. Yes, I can hear you.
Yes, thank you very much for inviting me to join this meeting today. And I'm really happy to meet you finally because this meeting is setting for 1 or 2 years ago. Because in the COVID situation, maybe we cannot uh, face-to-face meeting, so it's good. We can online meeting. Today, I will talk about the warfarin in cardiovascular surgery. I will add on the topic that Dr. Lin that already talked. I will don't talk about the pharmacology or anything about doses and warfarin of the warfarin. I will pay attention to how to use the warfarin in the cardiovascular surgery. Yes, my hospital is the Chiang Mai University Hospital. We setting is around 60 years ago, and that meaning I was born is we have the 1,400 bed. We operate around 1,000 cases of heart surgery in each year, and we have the two operating room, one hybrid OR and 8 ICU bed, and we already set the hybrid OR 5 years ago for do the TAVI and aortic endovascular therapy. And this is data is our unit. We operate around nearly 1,000 or now 900 cases of open heart surgery a year. It go down in last 2 years because of the COVID situation, and we hope this next year it will increase to the 1,000 again. And we operate the congenital CBG valves and also the thoracic aortic aneurysm. We have the vascular team separate to do the infrarenal aortic aneurysm, and also we have the team that do the lung. So we have the unit of the lungs surgery again also. Today I will talk about the role of warfarin in the cardiovascular surgery. I will talk about the four topics: valvular heart disease, coronary heart disease, congenital heart disease, and acute pulmonary embolism. Also, I will add on our warfarin clinic in our hospital. The first one is the role of warfarin in valvular heart disease. As you know, the valvular heart disease continue the significant social impact. Every year in Thailand, we operate around 2,500 cases of the valvular heart disease each year. So in our country, rheumatic valve disease is representing the most common indication for intervention. This data I show is from the Thai 88 database. So it's our Society of the Thoracic Surgery. You see that it's around 1,500 cases or nearly 3,000 each year we operate the valve replacement, and also we operate around 1,000 cases of mitral repair or aortic valve repair is also. Half of this or more than half is rheumatic heart disease. It meaning is have to use the mechanical valve. Is also we have to use the warfarin. The first implant of the aortic valve in 1965 by Hagen. After that, the development of the prosthesis is start from the ball and cage to single tilting disc, and the bileaflet valve is the third generation. It's because of we try to improve the hemodynamics of the patient of the valve, and also we try to reduce the complication just like the thrombosis and embolism of the valve. We know the mechanical valve is the highest longevity and most durability when you compare to another type of the valve. But the problem is you need to get the high intensity oral anticoagulant therapy to prevent thromboembolic complication. If you don't eat it or you don't control the uh, the warfarin, the clot information and maybe struck the valve, maybe the patient come back with the heart failure and maybe death. So not only in the mechanical valves, it's also in the tissue valve. It's some situation the patient have the clot in the leaflet, like the same. When we look back, why we use the warfarin in the mechanical valve is you have to look back to 1994. Kenneth Gitter and Rosendale is do just right meta-analysis, review the patient is allow 50,000 cases a year, patient years to review for the hypothesis mechanical heart valves about the thromboembolism and major a valve obstruction. So they show that when you push the valve in the patient, if you don't give anything to prevent the thrombosis, the patient get the valve thrombosis around 2% every 100 or 2% per year, or major embolism around 4% per year. But if you give the antiplatelet or just like aspirin or dipyridamole, the incidence of valve thrombosis is not change much, but the major embolism is reduced twice. But if you give the warfarin, you see that the valve thrombosis reduced to nearly 10 times, or So why we use the warfarin for the mechanical valves in after that. Now in the market we have the three types of the valvular prosthesis. First one, your mechanical valves, bioprosthesis, and transcatheter valve is coming. And we talk about the surgical valve. I don't talk about the TAVI too much in this situation because they are really high cost. So the simple now is still debate between the mechanical and tissue valve. It have benefit and adverse effects. When you use the mechanical valve, you sure that its durability is very low. But the problem, you have to take anticoagulant, especially now mechanical valve, you use only warfarin, and you have to check the blood levels for the warfarin whole life, and it increase risk of bleeding. The tissue valve is good. Is some people when you put the tissue valve or repair, is maybe not need to get the anticoagulation, but the problem that the patient have this valve have the structural valve deterioration depend upon the age, so that increase risk of reintervention. So when in the recommendation of ESC 2021, when you choose the valve, if you talk about the age in aortic position, if the patient is younger than 60 years old in aortic position, they suggest to use the mechanical valves. If the patient is younger than 65 in mitral position, they suggest to use the mechanical valves. And also in the patient with the older than 65 in aortic position, they suggest to use the tissue valve, and in mitral valve is they suggest to use in 20 years. But it's different when you look back, when you look in the ACC and AHA guideline, they suggest that the cut point that suggest to use the mechanical valve is 50. And below the 50, they try to use some group of the patient can do the loss operation or aortic valve repair. And the patient is need bioprosthesis in aortic valve. They suggest is cut point is 65. And also in the mitral, the cut point is 65. It's cut 2A and some is cut 2B. We don't talk about if the patient don't need to take the warfarin or contraindication for get a warfarin, we don't give the mechanical valve for the patient. Our unit prefer the use the bioprosthesis in patient is older than 55, and the pulmonary autograft we also do it in the childhood and younger than 40 years old, because we still discuss with the patient if they need the active life and don't need the take the warfarin. Maybe we can do the loss operation for them. So there is a gap between the two society. So why? Because the AHA tried to reduce the age that cut point to use the bioprosthesis. Because last 5 years, they launched the new treatment of the pericardial tissue, we call the ciliary tissue, because they changed the principle to treat the pericardium valve, and they hope that it can longevity or increase durability of the tissue valve. So now in the FDA is approved when you put the tissue valve in aortic position, if the patient is 55, and this valve is also have the platform that prepare for the TAVI in the future. So for the anti-thrombotics from the AHA guideline, you sure that vitamin K antagonist is the first class 1 recommendation in mechanical valve. No X, heparin only is not enough. So in aortic position, yes, is low risk of the thromboembolism. So you keep the INR 2.5. If the aortic mechanical add on with AF or high risk of thromboembolism, maybe you increase the INR to 3. And in mechanical mitral, you keep the INR 3. All of the mechanical valve, they suggest to use the aspirin low dose together. Also in our unit, we use the aspirin and warfarin together. And in the bioprosthesis AHA guideline, suggest that you should be on the warfarin, no act in the first 3 months, both mitral and aortic position, because the first 3 months we waiting for the endothelialize of the endothelium to cover the raw surface in the valve. After that, in the aortic position, you can use the aspirin if the patient in the normal sinus rhythm. Also, in the mitral valve, if the patient in a sinus rhythm, and the patient is mitral regurgitation, maybe you can use the warfarin lifelong, use the aspirin lifelong. In the TAVI, is they subject to treat the same as the aortic valve. If you don't risk of bleeding, maybe you can keep the warfarin in the first 3 months. After that, you can use the aspirin also. In the ESC guideline is a little bit different. They don't suggest to use the aspirin add on the vitamin K in mechanical every case. They suggest that if the patient have the Coley disease or the list of the Coley disease, maybe you add on the warfarin. In the tissue valve, in the mitral, aortic, and TAVI, it look like the same but different. But ESC is look strong suggestion to use the oral anticoagulant, especially NOAX, after 3 months. So when you choose the mechanical valves and you try to control the INR, you have to think about that it's not only the type of the valve, not aortic, not mitral, not enough in the mechanical processes, because there is a factor that depend upon the patient list. Just like the mitral position, you need the higher the INR. If the patient have the AF, the lead factor. If the patient have nitral sensitive or LV function is bad, you need the more target of the ANR. Also, the type or the generation of the valves. The first generation, just like the bowel and cage, that highest risk for thromboembolism. The median risk is, second generation valve. The low risk is just like the century open pivot, just like Onyx or Metonic core. You can use with INR 1.5 if the patient don't have the risk factor. In 2015, they try to reduce the INR, reduce to use the anticoagulant in mechanical aortic valves. It proactive, it try for the Onyx. Onyx is a new generation bileaflet, and they design for thrombo-resistant surface and open pivot to reduce the turbulent flow in the valve. So they suggest that this design can reduce the thromboembolism. They reduce the INR in aortic position compared with the between the 1.5 to 2, and another group is 2 to 3, just like the standard. They found that the bleeding is reduced when compared in the low dose of warfarin, and stroke neurological event, although mortality is not different in two groups. So after the proactive, they suggest that if you use this valve, the Onyx, you can keep the ANR 1.5 to 2, but you have to add on the low dose warfarin, aspirin together in treatment. We also have this valve, and we use it for 10 years. I think we happy for this. This type of mechanical valve is the largest design of the bileaflet of mechanical valve. For the NOAC in valvular heart disease, yes, it starts from realignment, is use the bicatan in mechanical valve compared with the vitamin K, is bad result. We found that you use the NOAC in the mechanical valve immediate post-op, increase death, increase thromboembolism, and also increase bleeding. So we stop this trial already, and maybe this time, you see after that, the recommendation in the mechanical valve still warfarin, not NOAC. But they come back to think that it's maybe because it's too early to use the NOAC in mechanical valves. So they suggest that if you waiting for 3 months after endothelialize the low surface, the NOAC may be used. We have to waiting for this PROACT trial again, because now in the study. So in conclusion, this coming in this year, you see, the green one is meaning they're safe for the NOAC over the warfarin in the native valve. Every native valve except mitral stenosis and also rheumatic heart disease. In the mechanical valves, NOAC, no. In the trial, you can, in the mitral, no. You have to use the warfarin. By hypothesis, it look like to chip if the patient have the atrial fibrillation after 3 months, NOAC may be over better the warfarin. But if the patient in sinus rhythm, you don't need anticoagulant after 3 months. The second topic is about the lower warfarin in coronary bypass surgery. Actually, the coronary bypass surgery, we don't need to do to treat with the NOAC or the warfarin or oral anticoagulant, because after CVG, we follow the PCI in the ACS patient. We use the DAP. as aspirin, low dose, and add on with the P2Y12 inhibitor, and for 12 months, and we stop the P2Y12, and after that we continue the aspirin lifelong. When we have to use the oral anticoagulant in situation with after CVT, actually we don't have the guideline or the recommendation to use the oral anticoagulant in the CVT. But we have to look back the recommendation in the PCI patient. So they suggest that in the PCI patient, if the patient have the AF, the patient have the mechanical valves, or the patient have the history of thromboembolism, it should be add on the oral anticoagulant with that. It meaning triple therapy. Also the history of the pulmonary embolism. So if we plan to start the triple therapy for the patient, is very dangerous because it increase risk of bleeding. So if you need to start triple therapy in the PCI patient, you have to use the NOAC. It's better than warfarin. And if you cannot use the NOAC, you should be reduce the dose of the warfarin to 70%, and you have to use the clopidogrel. Don't need to use the decakilo or pasugel or anything that stronger than the clopidogrel. You use the low dose aspirin. In our unit, we don't use the triple therapy after CBT. If we need to use the oral anticoagulant, we still use the warfarin because the cost is different. In Thai baht, warfarin is about 5 baht a day. But if you use the NOAC, it meaning 200 to 300 baht a day. It's different too much. We use the NOAC only the patient have the indication, just like too old or cannot take the warfarin. And we also use the oral anticoagulant in this situation. Some patients have to do coronary endarterectomy because nowadays in the PCI era, we get the patient is now up to 50%. The patient don't have the lumen for CAP, just like this choreograph. Total occlusion diffuse and stent along the coronary artery. You cannot grab and you cannot perfuse. So in this situation, I prefer to do the endarterectomy. Just like this patient, we do the endarterectomy with the beating heart. We open and traction the calcification. Also, you see that just like the pipe in the coronary artery. And we have to remove that all because you cannot remove only one segment. I will follow along the LVD to remove the calcium and cholesterol. After that, we patch with the lima or lay long or lay patch. Yes. Now, more than 50% of my patients that I get from the cardiologist, diabetic diffuse disease. So you have to do the endarterectomy. In this situation, we use the heparin infusion after operation, and we start the warfarin, maintain the INR 2 to 2.5 for 3 months. After that, we stop warfarin and we continue aspirin. And in the coronary disease, we also use the oral anticoagulant in the situation with mechanical complication, just like post-infarct VSD repair. because there is some space that form the thrombus, also the LV ventricular dysfunction, also the prosthetic in the ventricle. Actually, we use the warfarin to 2.5 INR 2.5 to 3 for 3 months. Also in the rupture, we have to repair the free wall. So we use the warfarin because the geometry of the LV is changed and maybe form the clot in the cavity, and in the mitral valve replacement, yes, in active MR that you have to on the warfarin. The third one is low of warfarin in the congenital heart disease. We also do the congenital heart disease. The most important, operation that we use the warfarin in the Fontaine, because in the venous tunnel and lower floor, and you put the prosthesis valve, prosthesis gap in the tunnel is meaning is induced clot, and also in the patient with tetralogy with PA with MAPGA, you have to reconstruction the PA just like this picture. You have to give the warfarin. Actually, I give the warfarin in the Fontaine to keep INR to 2 to 3 for 1 year. After that, we continue with the aspirin. Mechanical valve replacement in the children, we keep the INR just like the adults. And also, if we have to do the bypass of the artery or the stent in the peripheral artery, we suggest to use the warfarin. So from the AHA guideline, they don't suggest to use the vitamin K antagonist in the Fontaine, except the patient have the atrial fibrillation or risk of thromboembolism. But in our unit, we discuss with the cardiologist. We happy with to use the warfarin for 1 year, just like I said. The last one is we talk about the warfarin in the acute pulmonary embolism and Sept. We also do the pulmonary embolism that as we know, pulmonary embolism is clot from the deep vein thrombosis and floating to the PA and cause the circulatory overlap or cause of the hypoxia. Actually, the PE management is based on medication, just like thrombolytic or anticoagulant. Is only 1 or 2% that you need to do the thrombectomy with the surgical thrombectomy. And actually, after resolution of the clot, we will continue the warfarin, not NOAX, for 3 months at least. You have to continue in what situation, just like Dr. Lin said. If you have the cancer, if you have the antiphospholipid antibody syndrome, or you have the just like the anticoagulant defect in the body, maybe you can continue for lifelong. That we keep INR 2 to 3 in the pulmonary embolism, and we also do the CTEP or chronic thromboembolic pulmonary hypertension is caused from the chronic pulmonary embolism, and we have to remove the endothelium or the clot in the chronic. It's very difficult, but actually total solution that you have to keep the lifelong anticoagulant and the warfarin, because we discussed with Dr. Schaefer from Germany. She just came to operate CTEP in the patient with my young staff friend for the CTEP. It's okay that don't talk about the NOAX in now. In the CTEP, you have to use the warfarin lifelong. In Thailand, we have the guideline for treatment for anti-thrombotic therapy. They suggest to use the warfarin you see that in the patient with deep vein thrombosis, pulmonary embolism, tissue heart valve, mechanical heart valves, myocardial infarction, atrial fibrillation, and mechanical prosthesis valve. Finally, we will talk about the Warfarin clinic because the Warfarin is just like Dr. Lin said. At first, we use for the rat killer, so rat poison. So the Warfarin is limit pharmacodynamic and pharmacokinetic. It narrow therapeutic effect and different response person by person. Warfarin overdose could be severe bleeding and could not cause a ineffective treatment. That's why, because we setting the Warfarin clinic service in our hospital because every year we have the new case of the Warfarin more than 100. It meaning we open our unit 30 years. We have the case that use it around 30,000 cases. It meaning visit it 30,000 visits each year. So that's why we cannot control anything for the Warfarin patient because some patient lost follow-up, some patient cannot achieve the goal of the treatment. So we setting the Warfarin clinic in our unit from 2013 is multi-disciplinary team. We use the pharmacist, nurse, and surgeon together to take care of the Warfarin clinic. And the goal of the Warfarin clinic is optimize patient ANR to reach the therapeutic range and monitor bleeding complication, improve medication adherence, and support with the team. So we get our target on the new case. The patient have abnormal length of the ANR and the patient have DAP therapy problem. So we monitor the INR every 2 months until the patient stable. And we provide dosage adjustment by the pharmacist, screening and positional duct interaction by physician and the nurse, and provide subject, prevent and manage problem together with the team. So we have the calendar and the booklet for the patient, and also we have the YouTube animation for the patient to learn to do the Warfarin. We found that we can reach the target therapeutic range of the patient is more than 10% in 1 year. And also we can reduce the complication or the drug interaction, the bleeding complication, also the dosage and drug interaction of the patient is better when we compare with the before we have the Warfarin clinic. I think we hope when you have to use the Warfarin in the mass product patient, maybe it's better you can use the Warfarin. This support by SPS company to setting this Warfarin clinic. Thank you very much.
It is our great pleasure, Dr. Suri, for sharing your professional experiences. According to Agenda 3, now is the Q&A session, and any things you want to know about the role of Warfarin are welcome and drop in chat session.
You have received 4 questions from the audience. I wonder, Dr. Lin Daozhen will be happy to answer these questions, and if necessary, Dr. Suri is also invited to answer to help Dr. Lin Daosen for answering these questions.
And thank you, Professor King and Dr. Suring. One question I see is use of NSAID, paracetamol, and PPI in warfarinized patient in daily practice. That's a very good question. In a daily practice, we use NSAID, para, and PPI in most of the patient. So you can use these drugs, but be careful. Your patient is target INR in the normal range, and if there are any liver deterioration. Regarding PPI, I preferred pantoprazole. And what about the Dr. Suring preference?
Sorry, maybe you can ask again. Sorry, I cannot hear very well. Can you?
One question is, how should we use NSAID, PPI, and paracetamol in warfarinized patient in daily practice? And in my practice, I use PPI, pantoprazole. And what's your opinion with other PPI in warfarinized patient?
PPI. What do you mean PPI? Right?
Yeah, the question is the choice of proton pump inhibitor in warfarinized patient. I preferred pantoprazole in warfarinized patient. And do you agree with me?
I don't understand the question, sorry.
Sorry for presentation. Yeah, so I'll proceed another question.
Yeah.
Professor King.
I should answer in if you allow, I would answer in Myanmar language.
Yeah.
The question NSAID go warfarin out the lure below time around me. Solution NSAID is a potentiating effect to the warfarin. The NSAID out the lure so Warfarin diclofenac now saliclofenac aciclofenac patient now the warfarin and check dead so long term pay NSAID payment 3 time warfarin and tell 3 time. No? Now PPI routinely the warfarin lunarima payly machine. If we have a bleeding public ulcer bleeding, banya bleeding chance the GI cover and in a PPI tape payly shida. Paracetamol and a very few side effects to the GI tract. Paracetamol there's no drug interaction between paracetamol and warfarin. So paracetamol carry energetic dome first line in it warfarin patient. I hope it answered the question. Another question, Dr. Lin Daosen.
Here I can see another question. Is there target iron difference between valvular or non-valvular AF and recently valve repair patient with or without air? I think the target iron is the same between valvular, non-valvular AF and the recently valve repair patients. And another question is asking about the breaching, hepatic breaching. We usually stop warfarin for 5 days before the procedure. and then we change to heparin. But it is very individualized, and it depends on disease condition or why you give the warfarin to patient. And regarding NOAC, it's difficult to answer. Should change to NOAC in breaching? It depends on the individual. And another question I see is the use of NOAC in mitral stenosis instead of warfarin. According to guideline, up-to-date guideline, we still use warfarin in mitral stenosis, not NOAC. But our medicine is evidence-based and changing day by day. So maybe next 10 or 20 years, NOAC may be used in mitral stenosis. And that's my own opinion. And what's your opinion about NOAC in mitral stenosis, Professor King?
Rheumatic case က more thrombogenic ဖြစ်တဲ့အတွက်ကြောင့် rheumatic case တွေမှာ rheumatic valvular heart disease တွေမှာတော့ warfarin ကတော့ time honored ပေါ့အခုချိန်ထိ standard တွေနဲ့သုံးလာတာ NOAC နဲ့ကတော့ကျွန်တော်တို့နိုင်ငံမှာတော့ဒါ trial တွေလုပ်လို့မရသေးဘူးဒါပေမဲ့သူတို့ရှိမှာတော့ valvular heart disease တွေမှာ NOAC သုံးတဲ့ study တချို့တွေတော့စနေဒါပေမဲ့ conclusive တော့မဖြစ်သေးဘူးဆိုတော့ we have to wait for the result နော်ဒါ safe side ကတော့ warfarin ကတော့ဒါ time honor ကျွန်တော်တို့အခုချိန်ထိ data တော်တော်များများရထားပြီးသားဆိုတော့ warfarin နဲ့သုံးနေသေးတာပေါ့ဟိုဟာNOAC သုံးဖို့ကတော့နည်းနည်းအချိန်နည်းနည်းစောင့်အောင်ပေါ့ result တွေစောင့်အောင်
Actually, NOAC is not safe. You have to know that. When the patient take the NOAC, you prepare the patient for surgery is very difficult because it don't have the antidote. And some drug in the NOAC have the antidote, but it's very expensive. That's the problem of the NOAC. So until now, I don't know, maybe we use very selectively in the patient. Just like the patient with after repair with the cockness. Yet the patient come back to the sinus rhythm or you can control the rate. But actually it's very low risk to embolism. In some patients, the cardiologist give the NOAC for this patient because they think that is risk of the embolism is not disappear from the cockness surgery. That they give the NOAC. Actually, the NOAC in our unit is used not more than 10 to 20%. The most is we still use the warfarin because after we setting, you have to setting the line of the care or the warfarin clinic. The patient is, very simple, easy to take care of the warfarin. In Thailand, still don't have the bus stick to self-monitoring, but now everywhere in Thailand can check the INR. So it's now more easier than 10 to 20 years ago that the patient take the warfarin.
Thank you, doctors, for sharing your knowledges and answers. According to Agenda 4, please kindly allow me to present our product Warfarin information. Our product Warfarin is well-known warfarin sodium with different colors for different strengths of 1, 2, 3, 4, and 5 milligrams. With different colors, it really gets benefits in preventing from wrong choosing of required dosage of Warfarin. We proudly import our healthcare products from well-established pharmaceutical manufacturer from Thailand, SPS Group of companies, which receive GMP PICS approval. Here in Myanmar, Our Selling Trading Company Limited distributes these healthcare products and medicines to fulfill our healthcare requirements. It is our great honor to supply healthcare supports for patients from different levels. Here is hotline number of our company. Purchase orders and inquiries can be done via this number. Thank you. Now is the final agenda 5. I would like to successfully accomplish today our webinar event. Thank you very much, doctors and healthcare professionals, for your time and interest in our educational program. Now is the time to finish this webinar, and please allow me to successfully complete today our webinar event for Royal Warfarin in cardiovascular products. Thank you so much for your attention. Have a wonderful day.
Thank you. Have a good day.
Warfarin is the oral anticoagulant which plays a major role in preventing of the blood clotting in coronary occlusion, pulmonary embolism and deep vein thrombosis. However, it is the narrow therapeutic index drug. Therefore, all procedures need to be strictly controlled under the high-quality conditions starting from API sourcing to manufacturing in order to assure the high-quality standard for all manufacturing batches. Our aim to manufacture Warfarin is to support the equity of patient access for the high-quality product. Our dedicated process includes sourcing the high-quality API manufacturing under the PIC-as certified plant, which is the well-acceptable standard worldwide, and analyzing the product by our highest standard ISO 17025 certified laboratory. This is to ensure that all batches of Warfarin are manufactured under the strictly controlled condition and assure the quality before releasing to the market. 5 strengths of Warfarin were passed the quality assurance by Department of Medical Sciences, Ministry of Public Health, the government agency who inspected and announced the list of products which meet the quality standard for the hospital to use as the reference when purchasing the medicine. As a result, Warfarin was in listing in the hospitals nationwide. We also conducted the bioequivalence study of Warfarin to ensure the efficacy of our product. It was published in International Journal of Pharmacy and Pharmaceutical Sciences. And it showed that both reference product and Warfarin were equivalents in terms of efficacy and safety. In order to support the healthcare professional to easily manage Warfarin dispensing and consulting for better patient communication and increasing patient compliance, we have special designed our product appearance and packaging, prepared material for patient counseling, and supported the healthcare professional education. We provide 5 strengths of Warfarin including 1, 2, 3, 4, and 5 milligrams for the easier dose adjustment. Each strength was designed in different color to reduce the dispensing error and promote patient recognition. To avoid the administration error, the color of the Alu blister packaging was matched to the color of each tablet inside. For the tablet identification, each tablet was embossed with a numeric character representing its strength. Our Alu packaging promoted light and moisture protection. The unit dose packaging helped reducing the administration error. We provide the supporting material for easier medication and better patient communication, including Warfarin dosing card which support Warfarin dose adjustment, patient chart label to identify warfarin patients which need the special attention from the other patients. Counseling flip chart to educate patients about their disease and their necessity of use warfarin in order to promote patient compliance. Warfarin patient booklet which contain the information of warfarin administration and patient recommendation that can reduce the medication error. Continuously arrange the healthcare professional education program to support their knowledge on disease, anticoagulant and the patient management such as symposium, congress and workshop. With a high quality and high efficacy product, the warfarin supporting material, and the education program, our warfarin gained the trust of the hospitals nationwide including the medical schools, public hospitals and private hospitals. Warfarin, the reliable warfarin and the healthcare professional partner.